And this is kind of like a, let's see how this goes. If we have like a 2 out of 5 and we're not real sure what that's gonna look like in use, we wanna test that before we come in standing, right? So we wanna see, can they do a quad set? So we wanna train them in long sitting to see if they can make a muscle, hold it, and then make sure that they can at least keep the knee locked in this position and hold a quad set. Now, of course, that doesn't have any weight on it and, you know, all that stuff, but at least we would know in that it gives us an idea of, I mean, they don't even have enough muscle to make a quad set, then that's gonna give us a real good idea of how we need to proceed and how we need to guard, right? So, so the first thing you'll do for training, if your patient's issue in stance is that they don't have, that they need assistance with their big problem is knee extension, then you're always gonna start here to assess, and if they've got a good quad set, then you know you can go ahead and then you would move forward back into a standing position on the well, I guess it would be this one. Just to be consistent with what we've been doing, because I've been facing that way and this has been the weak leg. So you would just do the quad set, have them hold it for 3, have them hold it for 5, and see what kind of contraction that they can get and sustain there. So that would be where we would start, and that's exactly what it says here in long sit quad sets. So if we go back to standing, we're going to take that. So we've already done something where we took the unaffected leg and put it up on a step, and we did loading and unloading of the leg. Now we're gonna do that again, but we're gonna focus on the knee extension when we come back down. Did this in when we were having the leg take weight, right? And so we did it before when we were just loading and unloading the leg, and you were just literally blocking because we were just wanting proprioception on the leg, right? So this time, we're going to take the unaffected up on the small step, weight shift onto it, and the affected knee is going to stay in, it's going to start out extended, obviously, because that's how it's going to be when we go, right, in the gait. We're going to start here, and then we're going to see if it will break, and then straighten again. So our job is to facilitate. They're going to do this part of it, obviously, because this leg works just fine. So you're going to tell them that your job is to step up and shift your weight forward, and we're going to see if we can get this knee to come into flexion and back into extension. We're training it in knee extension.
So we're gonna stay there, hold that, and just bend
No,
straight?
I'm exaggerating. So I'll show you the sequence.
Okay.
But so you would come up, go and you're gonna facilitate, probably gonna be on a stool for this one, so you can use hands instead of your leg, because now we're focused on something else. Now, if we're moving down to the knee, we now assume that the hip is in pretty good shape. And now we're not worried that the hip is gonna shoot out here and we need to be all up in here. We're now assuming that if we've moved on to the knee, that the hip, we're pretty good. So now we're gonna move ourselves as a therapist to the stool so that we can manipulate what the knee does. Again, normal movement is the goal. I'll get a word in a minute. So, does that make sense to everybody? So it's the same exercise. Yes, we've already done it before, but if you're doing it for hip proprioception versus training knee extension, it will not look the same. You should not be in the same place, and you definitely won't be focusing on the same thing when you do the exercise. Does that make sense? So yes, that will go in the same place. You will give your patient the same cue that you're going to take their good leg to step up on this, but that's the only thing that's the same about it. Okay? All right. Page 2. The last one there for the training the knee extension, you'll start feet together. Again, you're going to be on the stool as a clinician because we're not so worried about the hip now. They got pretty decent control of the hip, and now we're moving down to the knee. So you may have to still help weight shift, but you can do that from there. You don't have to have the hips to help weight shift. That's always going to be a thing in your neuro patients, because until that leg feels completely like normal, they're not going to do that on their own. So the weight shifting is always going to be there, but you can weight shift your patient from anywhere. Even if you have to throw a shoulder into their hip to weight shift them, just weight shift them. And when we get to gait, that is literally something that sometimes you have to do. You just put your shoulder in their hip and you just heave. So anyway, but you can weight shift, from here if you have to. So we're going to be on a stool to do this. So it says lift heel, flex knee, and hip, slide toe, in swing backwards. So we're going to start in like tandem with your actual affected leg for out front. So you'll have to have your patient lean into the table, and then depending on what muscle grade they are, if they can gradually put it forward for you, if you on the stool have to help them bring it forward, that we'll need here, and then you'll want to have them weight shift off of the table to where they've got weight on both legs initially, okay? And then, because what we're gonna do is you're gonna weight shift back over to the good side, and you're going to go into flexion in the hip and the knee and up on the toe, and then you're gonna drag this backwards, and again, if you need to help facilitate the drag, and then we're gonna go into knee extension from here. And then we'll go back and into knee extension here. So we'll be going into knee extension for terminal in both directions, right? So we'll be going. we're not doing heel down because that, we addressed that during swing, and again, we're still working on stance here. So even though this leg is moving, it's still addressing the stance deficits of having the knee be an extension for beginning the stance phase. So we're not working on heel strike yet. We're working on being able to stance on an extended knee. Okay? So that last part is going to be a weight shift. So getting the knee locked, getting the knee in extension, hopefully actively, but if not, use some facilitation, and then weight shift. Weight shift off, go into flexion, drag, put everything into extension, weight shift. So that way we have terminal here with weight, that's stance. We have terminal here with weight, that's stance. Make sense? Okay. So those are the two, or that's the ones for training the extension. And I'm gonna go over the hip flexion control, and then I'll demonstrate the other two categories, okay? So, of course, hip flexion will be what we will need for, eventually for some, to begin swing. So, if we are nearing, we've got stance now, we can take weight, we've got decent proprioception, the hip doesn't come out. Now we've addressed the fact that we can go terminal and terminal. Now we're gonna start looking at what does the hip flexors do? How much control of the hip flexors do I have? So we're going to initiate knee flexion, unweight the lower extremity, facilitate at the hip flexors for the LE to come forward, and lift the leg up to a small block. So this is gonna be the first time that you're actually gonna be moving the affected leg with purpose. Okay, so again, this is in prep for making the stance leg become the swing leg. So this is like the transition piece. That's some tough tape. It does not want to tear.
There's a few of them that I just cannot tear.
I was getting ready to
Same
say.
Giving us a lot of trouble our first ortho.
Yeah, it did.
I was getting ready to say, I have been tearing tape for flat objects, just enough. So you can start with tape, you can start with things that are low profile, because we are in the process of figuring out what kind of hip control that we have, flexion control. So initially we're gonna start with tape marks, because again, this is about our stance phase. So we're gonna unweight, so it's about that weight shifting, and I'm exaggerating it for myself so that you can see. I'm unweighting, I'm reweighting. So it's, then you want back to equal, so that they will have to shift off again. What we don't want is this. this doesn't help us. You can't see my knee. I haven't shaken it well. No judgment. So, and let's just make a habit of starting anything for swing back. Natural movement. We don't ever start swing from here, do we? No. So, this one, and it doesn't have to be way back here, but just make sure that you're kind of stutter stepped. And you're just gonna do a little bit of hip and knee flexion.
We're still evening out the weight on both legs, like as you're like kind
Yeah.
of tandem now.
Back now, I'm back to, yeah, even when you're in stutter, even in stutter step, you're equal.
Yeah.
Think about when you walk,
Yeah. Okay.
right? Yeah. So again, normal. Always default back to normal. And so if you get lost in this process, as you're doing the exercises or as you're doing your practical or as you're doing anything, okay, in this process, where would their weight be? Because this isn't it. Because this is just swinging freely.
Mm-hmm.
That's not, we're trying to get the body back into the normal mode of just doing things that it should be doing. So that's why we want to start back here, because this is where the foot would be beginning from. Now maybe not in full stride, obviously, but even just a little bit of a stutter step is going to give a little bit of a stretch right here, which again is enough of a mental cue for that patient that that leg is not going to start here equal and even with the other one. So even if it's just that, because sometimes that really is enough to throw off the balance quite a bit. You know, not having them equal and shoulder width apart and having that perfect base of support. So even if you can just stutter it enough just to get a little bit of a stretch on that hip flexor, just to register with the brain that that one is slightly behind, because that's where it should be when we're doing, when we start swing. So, yeah, it's just a shift over. Oh, I forgot to bend. So you're just trying to get them to weight shift, and step forward. Targets are there so that they've got something externally to look at, so that you're not having to continue to say, step forward, step forward, step forward, step forward. That way you can say, we'll start on the outside and go inside, and then we'll go inside to outside before we quit.
What's a good way of explaining that to a patient? We can't say let's do weight shifts, right? That's a little too.
Well, you don't want them to think about that part of it.
Okay. So just
You're
saying
gonna tell them, you know, that we're gonna start, and I want you to step on each line starting on the outside and bring it back.
Okay.
And then you are gonna provide the weight shifting.
Yes.
If they're not doing it, then you're gonna provide that part with your facilitations, and hopefully their body will follow along with what you want it to do, just like it did with some of the sitting balance stuff when they weren't doing what you wanted them to. You could put hands on and make them do what you wanted them to do without verbally cueing them. Yeah, so we're gonna start from back here, we're gonna step forward. I do want you to focus on making sure that you bend your hip and your knee as you come forward. Okay? And then you can progress to things that are a little higher profile. But still not necessarily tall. And on these lower profile items, you can probably still get a decent weight shift onto them, but you're not gonna be able to actually step. But we're getting more hip and knee flexion because we're having to lift, right? So now I'm still working on control, but I'm still not doing this, right? And then once you conquer the low profile, then you can go to some higher profile objects. Where they've really got to kick in that hip and knee flexion in order to hit the top. And still, they're coming back into stance, into this terminal right before toe off. Yes? Okay.
Would you say we'd still be on a stool in case they needed like facilitation, like if they were two?
Yeah, you're gonna be down on the knee level for this because as they may need help bringing it up. You may have to help support a little bit against gravity depending on where they are. And then you're gonna want to be close to make sure that when they put the weight back here, that the knee doesn't. Yeah.
Okay.
So, questions on the rest of the stance legs? Okay. The first time you have to guess at the step, and when you do this, if you don't get what you want out of the stance leg, then the next time you may have to move the step out a little bit. You may have to move the step in. I need you to be able to use that clinical judgment that the stance leg is not doing what you need and adjust your activity. It's not a fail. It's not that you're not doing it correctly. The fact that you're moving it means you are doing it correctly. The thing that is bad is if you continue to do it when nothing is going on the stance leg. That's the wrong thing to do. Okay, we're not doubling down that this is where I'm leaving the step. That's where I've got it. Oh, that's where I gotta leave it. No. So, you wanna make sure that what's going on is what's supposed to be going on. So again, your patient can, fingers on the table, depending on how much assistance they need at that point, you can adjust it higher or lower. And you are going to, again, you can be real close. You don't want to get in their way, but on this stool, I'm everywhere. And I can get him just like this if I need to. My shoulder is in his hip bone and I can sit him in my lap if I need to, right? So, everything's pretty safe here. I can throw that knee here and this knee here if it buckles. And it's not going anywhere, okay? He's like, nope.
I was
like,
trying it.
He's like, I'm in jail. So, if something goes awry, you are close enough to make the adjustment that you need to. But they also have to be able to move, which is sometimes tough because, you're like, where do I hold? Where do I touch? What, tough as new clinicians, I'll admit, but you have to let them move because normal movement is what we need. And if we pin them in a box, they can't get normal movement, right? So, we're gonna instruct our patient. We're going to use the step again. I know we've used it before. We're gonna use it kind of in the same way, but I'm gonna be focusing on a little something different. So, we're gonna now be focused on your knee. Now that we've got your hip a little stronger, we're gonna be looking at how your knee, how it kind of like wants to go on us sometimes. So we're gonna be focusing on trying to get it a little stronger and stay extended for us when we want it to stay locked, okay? So what I'm gonna have you do is I'm just gonna have you step up on the stool and then back down. Okay. All right, that's your part of the job.
Okay.
All right, so again, I'm gonna have hands. Usually, I'm gonna put what I feel like, and even though I'm right-handed, I lead a lot of treatments with my left one, I don't know why. But I usually like my left one right below the tibial plateau. It makes a great handhold. I had to show mine, you gotta show yours. See right here?
My legs are very hairy.
So are mine right now. See right here? So, and that's not terribly uncomfortable for the patient. And if he does go, and then this will keep him from going into too much hyperextension because I can give a little bit of counter pressure with my other hand. And then that way, if I need to help him scoop or anything, I've got both hands on something that, yeah, I'm touching hamstrings, but eventually, as I come back, I'm gonna let off of those. Right, so, sometimes it just can't be helped for safety. So. Alright, so go ahead and just step up on that stool. I want you to put your whole foot up on it.
Okay.
Now, alright, and we're gonna try to leave this one on the floor.
Okay.
So just step up. Okay.
My
Go ahead.
fault.
Nope.
Okay.
I wanna facilitate what I want you to do, yeah. That's what I'm trying to figure out where this is probably gonna be best this way. There, joint line. That make you wanna bend your knee?
Yes, it does.
Okay. Now, if you were having trouble, I would have to flip, because I'm having to do this to get him to bend his knee, because he's just wanting to just do what you were naturally doing. And he's keeping it straight. So I have to do something, because I don't want to say, oh, no, Blake, I need you to bend your knee on this side when you come up. Because that's going to mimic what? What will he be doing on this side?
I mean, keeping my knee straight, just extending my hip,
Right, but toe off.
toe off.
You don't toe off with your knee straight.
Yeah.
Right?
Right.
So again, I'm focused on teaching normal movement to this patient. So if I let you step up on that stool or that step and the knee stays locked, I'm not training the knee to lock,
Right.
but I'm also teaching you a bad habit that during toe off your knee stays extended. So it's important to make the knee bend. So if I have to facilitate that knee bend, go ahead and step up again. I may have to flip hands. If he's having difficulty locking this when we come back, you may have to move hands to make that happen, because the back hand might have to be on the joint line to get it to bend, and then in order to get it to straighten, then this one's gonna have to be down here. So you may have to flip your hands back and forth in order to get everything that the leg needs in order to do what you need it to do. That makes sense? Okay. So that one, you really just want that and he was shifting his weight pretty good, but if he wasn't, I can, so let's say he didn't want to take, so let's see, yeah, let's say he didn't, and he's trying to lift his leg and he can't, then I can always weight shift him. Just with my hands there too, to facilitate that. So if you need to weight shift, you can literally weight shift. That's why I like right under that tibial plateau, because I'm not really, shouldn't really hurt your patient. It's pretty stable right there, and it still gives you a pretty good hold to be able to influence where they're at. Not quite as good as the pelvis, but it usually, when we get to this stage, it's decent. to influence where they go. So, then the next one would be weight over there. I'm gonna bring this one back just a little bit. Just barely bring it through. Let's see. It might be easier without your shoe blade.
Nope.
I think it's catching the
Yeah.
it's catching the carpet. So what we're gonna do now is we're gonna start just a little bit in, not exactly tandem, but kind of in stride. Okay, think about that, because we're, all this is leading up to getting us out on the floor and walking again. So we're gonna kind of start in stride, and we're going to break and slide it forward, shift and lock, or then we're just gonna lock it, unlock it, slide it, lock it. Okay, so you don't necessarily want to emphasize the weight shifts for them, because you want to see what comes naturally, and then you can throw those in there if you need to. That makes sense? Because if you do, then you're giving them a huge multi-step process that might confuse the daylights out of them. Especially if it's somebody that you guys had like one-step command people, you had a phasic people, you had people that were confused, right? So as simple as you can keep it for everybody, the better, because then you don't have to learn to do it different for somebody else. So we're gonna start in step, in stride is usually a good way to put it, so they don't think that you want them to do tightrope walking. Because a lot of times if you say in tandem or one foot in front of the other, that's what they try to do, and that's not what we want, because we don't walk that way. So usually I will use the word the phrase in step or in stride. And then I'll usually just say we're gonna break into flexion, or we're gonna break at the knee and just slide it forward, so they know that I'm not expecting them to like lift this leg and bring it forward, and we're not focused on heel strike. That's not the point. And then I will help it do everything it can, but we're gonna slide it forward, then we're gonna step on it, lock it, and then we'll just go back to right where we started and lock it, and we're just gonna do that. From back to front is one, and we're gonna do it 5 times. And then I'm gonna hush. And we're just gonna let the patient, you can say, I want you to keep count, so when we get up back to here, that'll be 1.
Okay. Are we aiming for the tape?
No,
Okay.
the tape is for later.
Okay, making sure.
Yeah. No, the tape is for later. But you do want your patient to take, and the tape is you're gonna put that down for every patient, because Blake's stride is gonna be way different than Carly's stride. So, right? And I don't want to limit Blake's stride by using a tape mark that was already there. So, we have to go according to what our patient has. Right?
So are we placing the tape?
That's when we start doing the.
Right, but like in the sake of the scenario, because we want to make sure that it's good for their stride length, right?
Yeah, and again, you place the tape, you can always reposition the patient. You don't have to replace
Oh,
the tape.
okay. I was gonna say, I was like, because we kind of want to be here guarding the entire time, so we don't want to like take our eyes off of them and start placing the tape while they're already in the standing position. So right, you know what I mean? So like we place the tape initially before we start to get them up and start doing things.
Yeah.
And then if need be, they can scoot back or whatever.
Yeah, scoot back or scoot forward.
Okay.
Yeah, so you'll adjust the patient, not the tape.
Right, okay.
Mm-hmm. Yeah, so, little, out here, just, yeah.
Okay.
Yeah, so again, we want them to be stable. We don't want them in a narrow base of support, we just want them in stride. So.
Sorry.
That's okay. I'm trying to get you to, yeah. Okay, and that's one. Two. So, okay. See how he's hesitant, even just as a fake patient, he's hesitant to put, like, come back and put the weight on it because he knows he's gonna move it again.
Yeah.
So he's like, no, because I'm getting ready to move it. Why do I wanna put weight over here, right? So as a patient that has issues on that side, it's gonna be 100 times worse. So you're gonna have to facilitate that last weight shift. Now, no, I need you to come back over here. Make sense?
Mm-hmm. I keep wanting to like move my foot a little
Yeah,
bit when you do
Yeah,
that.
no, and that's why I was like, nope. So, I mean, you just do what you need to communicate what you need your patient to do without your mouth. You don't want to use, and you guys kind of realized that in the last practical, right?
Mhm.
Threw you some wrenches.
Oh boy.
Yeah. Oh boy. Yeah, I mean, you know, I can weight shift him just like this, on and off of that. But your brain tells you, I'm anticipating, I'm gonna move that leg again. Why would I put all my weight on it? But that's what I need to tell the brain, because when I piece this into the next thing, the weight has to be here. So if we don't do that, then we're causing an abnormal pattern. That makes sense?
Are you weight shifting in knee extension or knee flexion? Like locked knee or unlocked?
Well, think about toeing off. When are you toeing off?
Knee flexion.
Right.
So we want to be weight shifted in knee flexion.
So, but are you still weight bearing when you get to this point?
A little bit, but not, I guess, as much. Maybe.
Well.
Okay. I guess I'm weight bearing more in knee flexion. Weight bearing more in knee flexion. I guess. Or I'm trying to
There's a
think.
little bit of knee flexion. The other great thing about this is you can always go back to normal, because that's what you're trying to mimic.
Yeah. Okay.
Okay? All right. So then we've got, so that does it for our knee extension. And then our treatment of hip flexion control, we would start with the marks. So we can kind of test it out. And like I said, I might need to scoop under here. That's a great place to scoop.
Mm-hmm.
If I need to facilitate knee and hip flexion, I can get both right there. And if it's a heavy leg, that's where I'm getting, because then it doesn't, then I'm not using my arm anymore.
There's a lot more force.
Oh yeah. And you know, some people's legs are heavy.
Mm-hmm.
So you have to be able to like kind of get in there and use your body weight use the body weight in the stool instead of using your arm muscles. If it's just a facilitation, it's not bad to use your arm muscles because it shouldn't feel like a whole lot. But if it starts getting really fatigued after a couple facilitations, then it's an assist, not a facilitation.
I know when we progress to higher objects, we can't bear weight going forward, but for the flat like tape, are we bearing weight when they come forward?
Mhm.
Right. Okay.
Should be, yeah. And he was,
Mm-hmm.
Okay.
yeah, he was shifting.
Coming forward and backwards.
Mm-hmm.
Okay.
Yeah. So, yeah, on the objects you can't, and that's when it shifts more. That's when the transition happens, because this is for hip control, and this is where we transition from the stance phase into the swing phase, and then we move on to the actual swing exercises. So this is the last one that we do.
Till we do swing.
Yeah.
Okay, that makes sense.
So, but that's a great place to scoop, and even when we go to do gait, that's a great place to scoop for swing when we're having trouble getting the swing leg out there.
I feel like having the pants rolled up also kind of really helps too. You kind of have that.
Oh yeah, well yeah.
I don't know if that plays any part in it, but
So you'll start with the flat tape, and you'll have them come forward. And again, we're not doing heel strike yet at this point.
Mm-hmm.
So it's not so much that he is putting the heel down and locking the leg out in extension.
Because the knee's already been addressed at this point too,
Mhm.
I would say. So, okay.
Yeah, and that's why I said we're here.
Yeah.
I can lock him in jail at any second because
Uh-huh.
I'm right here.
Okay.
But he has to have room to move. So I just have to be like the hovering little hummingbird.
Be
I'm
prepared
Just,
to
just
face-
right, yeah, I'm just right here.
okay.
So we'd have him step there. And again, I would give him the cue to start on the outside mark and go to the inside and then come back. Making sure that I have told him that we have to come back, and each time he has to put the foot down and put weight on it, or whatever the effective cue is for your patient. So again, they don't think that they're just tapping objects. They come back to start and plan it, put weight on it. I wouldn't use shift, because again, that sometimes gets kind of weird for them. It's an easy word for us, but sometimes not so much for them. Do that again, but I'm gonna give you some flat objects. So I want you to start on the outside and work your way in, and we're gonna come back to start each time. Put our foot down, put weight on it, and then we'll work from the outside, or from the inside out the second time. Okay? All right, whenever you're ready. Now, if he were having trouble shifting at this point, but not having a whole lot of trouble lifting, I would come back up here, as to not interrupt what he was trying to do with the hip flexors. So, I could also tap Jenna.
All right. There we go. Okay.
Because we're not looking for a super smooth, movement or anything at this point. So if I'm up here and I want to give those hip flexors, they're a little buried, but if I want to give those hip flexors a little tap, see if it will help him lift that leg a little better as he's coming through. And remember, have him start from a little bit, because then that puts those hip flexors on stretch, and they should feel ready. And then I can have my hands ready for a weight shift assistance if I need to, plus a tap for those hip flexors. Okay? And then again, I'm just rolling forward as he rolls. I'm rolling back as he steps. So I'm just going forward and backwards with him. Okay, let's try.
So we go in, and then after this one, we go back out.
Yeah, I mean, if that's the instructions you give them.
Yeah. Okay.
And then you would just go to a higher, next time you just go to a higher object. Same exact thing. Okay, questions?
We're going from lower to higher just to get more flexion.
Yes.
Okay.
Because it's about flexion control and prepping them